Yes.
Correct.
So I wanted to start off, and this will take about an hour or so. So make sure you ask questions and you sort of sort out what's going on in the concepts, because it's really each of the new fellows comes from, and I don't mean to call you an old fellow, Nicoletta, but Nicoletta has a neurology background, so she knows all of this, right? She learned all of this in neurology. So the wakefulness, the big idea. So the big idea about sleep. So you have to have the big idea about the heart. You got to have a big idea about the kidney. You have to have a big idea about sleep. And sleep health is that wakefulness uses energy, increasing neuronal traffic complexity, and creates metabolic waste. So sleep, wake, and circadian rhythm are neurologic processes. They are the master regulator. Is the suprachiasmatic nucleus, and there's an article in the New York Times about circadian health in the magazine section. I will bring it back for people. So the current thing is people really didn't know what sleep did, and the two dichotomous kind of approaches that have been there since Socrates is that sleep either replenishes the body or sleep replenishes the brain. And so there were proponents on both sides. And while I don't necessarily think that it has to be either or, the brain has now sort of won to the extent that there needs to be circadian rhythm in the rest of the organ system. So the idea Tonomi in 2006, which was the big thing, which was sleep replenishes brain energy stores, reduces synaptic complexity, and resets synaptic efficiency. So that was his big idea. He had a variety of basic science as well as human studies out of Wisconsin. And he had measurements of brain energy being repleted. He had some idea about synaptic complexity being reduced. That is, you're learning things right now and your synapses are getting more complex. And that synaptic efficiency is that you get rid of the old synapses and you restore the ones that are important. So that was the basis for thinking about how sleep improves memory. And so Stickgold's conclusions about his studies on memory and sleep were all based on that particular hypothesis. So in Neergaard, 2013, came up with the original observation that there is a system in the brain called glymphatics. And I put down the YouTube video about her. This probably will be in 10 to 15 years a Nobel Prize. Because what she discovered and described, and it's not as though she herself says, I found it and it's new land. It was just hidden in plain sight. Is that the brain is the only organ in the body that does not have lymphatics. It has really no organized way of getting out the waste that is produced by cells that generally goes into interstitial spaces and then finds its way into the lymph system. And some terrific pictures that are only possible now with MRI of showing proteins that are there in the lymph nodes of the entire body, and nothing is in the brain. So the brain does CSF. It does it between the cells. It then goes to the blood vessels or around the blood vessels, and then sort of goes back down into the neck and hooks up with the vessels in the neck. There's a little mystery about that so far, and probably there are different ways that different animals do it. So that the the animal people argue back and forth of whether their model of the rat or the mouse or the guinea pig or the pig or the horse is the same as humans. But that's generally what the idea is. And so it drives metabolic clearance. Now, what happens is that she believes that when you are awake, that wakefulness not only increases neuronal activity, but it causes the cells to swell and creates an anatomic limitation to the flow of lymph, or to glymph, GLYM, that's done through the astrocytes. Now, I'm being very simplistic about it and very naive about it, but I go to this YouTube video. It's pretty intense. So once you're sitting there and you're talking to someone, and I talked to one guy yesterday, it says, oh, I don't sleep for 48 hours, and then I sleep for 18 hours. You sort of say, well, what basic brain things is he talking about that is disturbing him, or what sort of thing is going on in that brain that causes that to happen? And what are the consequences of those sorts of things? So is the consequences of behavioral insomnia, is that deterioration of neurons? Those are the sorts of things that I think that I want to bring about, is try to smash together this basic science and the idea about what do we learn when we talk to patients, and what are we hearing about their brain. So the biology is in your textbooks. It's in your areas in which you read here, and on the left is sleep, and on the right is wakefulness, and you will learn all these areas, but this particular system of the VLPO inhibiting the reticular activating system of the, who knows what the TMN is? Anybody? Even Nicoletta?
Tubermammillary nucleus.
Right. What's the Raphe? Remember that in neurology? Remember second year of medical school? Come on, guys. Neurology. And then LDP, PPT, I forget that all the time. What? Lateral dorsal tegmentum. And then the locus coeruleus, the LC. That's the locus coeruleus, the adrenal gland of the brain. It's bilateral. So you can guarantee that in September and October, I'm going to sit there on a Friday afternoon and say, okay, guys, let's put the brain to sleep. What are the structures that do that? And I will see if you remember that, because that's my one thing that I tend to do. So on the right, though, you see what are the things that produce wakefulness? And the first thing you see is it's much more complex. This red VLPO GABA is inhibited, and that the rest of the system is activated. And these are also then with the neurotransmitters. So TMN is histamine, the Raphe is 5-HT, locus coeruleus is noradrenaline, and among others, acetylcholine is the locus coeruleus and nucleus ambiguous. I'm sorry, the noradrenaline and locus coeruleus, and then acetylcholine, and then the thalamus. And acetylcholine goes up into the brain, and acetylcholine is your major alertness molecule. Now, there are 5, 6, 7 alert molecules, and there is also orexin in here. And so you can see that in terms of organization of state, is that if you want to say what evolved is wakefulness, and sleep was the default setting. It's pretty simple. And most of these regions can be identified in animal studies. Now, there are a lot of questions about this from the basic scientists. Many of them have used both chemical and electrical ways of knocking out all of these different neurons. And lo and behold, they affect sleep. So if you hit the left side and you say, I'm going to hit all these sleep-on nuclei, that these sleep-on nuclei do disrupt sleep. But miraculously, about 3 to 4 weeks later, the sleep is not terribly affected, which is recapitulated in the thinking of people that have traumatic brain injury, in which their sleep is really messed up, and that can then get somewhat messed up as they go along. Not that it gets perfect, but that it's amazing how sleep can reconstitute itself. So the reticular activating system, this is from Saper's work in the pons, in the midbrain, and projects up into the forebrain, and then back into the back of the brain. There are kind of two routes that activate things through acetylcholine through the thalamus, the posterior route and the anterior route for activating the brain for wakefulness. Now, the effect on arousal systems that the VLPO is again this area of the ventrolateral preoptic nucleus has GABA and galanine, and then these other nuclei that are involved. Now, how might you visualize this? Well, if you were in the 1930s and you were working as a Bell telephone operator, right? You would unplug various things and plug them into something else. And you would sit there and say, there we go, we got sleep. If you became a circuit switcher in the 1950s, you'd say, okay, let's do a circuit breaker, and things would turn off and turn on. And then if you were in now the digital age and the kind of the quantum age, you know that these processes are incremental, that the number of neurons that are in each of these areas has to get up to speed to be able to do what they need to do. So the VLPO has to be able to get a certain number of neurons that are giving a certain amount of inhibition that inhibits a certain amount of neurons and a certain amount of these arousal systems. So that what these basic scientists are doing is they're trying to give you the idea of where are the important structures, but they don't tell you much of the functional things that happens when you start talking to patients, and know that people are neither asleep nor awake, but they sometimes are in these fugue states in which they don't understand what's going on. Now, is that happening at the cortex level, or is it happening at the brainstem level? And there is interesting lectures that are on YouTube that are found in different spots, which describe the sleep being local as well as global. So local, this is the local view of sleep. And the global view of sleep is that different parts of your brain will fall asleep or wake up at different rates, different places and different things. So the other important thing that I was always asked about is this observation in 1997 of forebrain adenosine levels, that in the hours leading up to recovery sleep, that if you keep mice awake, that their adenosine levels in the forebrain go up, and that those are sleep promoting sleep. That's the sleep pressure that happens in the brain, and that's reduced by sleep. It's also reduced because it's adenosine. It's also reduced by caffeine. So this particular study was that showing that caffeine is an important inhibitor of adenosine function in the forebrain. Caffeine doesn't work on things like the serotonin system or the norepinephrine system or the acetylcholine system. It works mainly on the adenosine system, at least as I understand it. So what's the first commodity? What's the biggest commodity in the world? I'm seeing if you guys are awake now here, huh? Biggest commodity in the world. What is it? What do you think, Sam?
Oil.
Yeah. What's the second?
It's probably coffee.
Yeah, it's coffee. It's caffeine. So you sort of now know that that's how it plays out, and that's why we ask about caffeine. We've not had a lecture on caffeine metabolism and sleep in probably 10 years. But there are two features. One is that your caffeine metabolism declines as you age. And the other is that there are various polymorphisms in the adenosine receptor and its ability to change cyclic AMP that is functional between individuals. So, all right. Now, we put people in non-REM sleep. So how do we put them into REM sleep? So these REM onset neurons are in the lateral dorsal tegmentum and the pedunculopontine tegmentum. These are primarily acetylcholine, and then we'll get into the weeds. It's a little more complicated than that. But at one point, they thought that that the REM off neurons were in the locus ceruleus, although that's under dispute now. So we kind of know how to turn on REM pretty well, and it gets turned on actually by the VLPO, which is sort of interesting, isn't it? And you enter REM sleep through non-REM sleep, and that seems intuitively the case if you read adult sleep studies. But if you read children's sleep studies, as John does, you'll realize that people go directly into REM sleep. These little infants. In fact, REM sleep is the dominant sleep pattern in the Indian. So you got to remember that all these basic scientists are usually reading the adult literature and not the pediatric literature. And the pediatric people are sort of on an island sometimes when they're thinking about sleep-wake and its purpose. And remember that first slide was really the purpose of sleep in the adult. So there's a reciprocal interaction model of non-REM and REM sleep, and that these REM off and REM on neurons have different neurotransmitters that they engage. And as you sort of suspect that this is a gradual dynamic model, and that these really mean that certain sorts of up to threshold levels occur. And you can, I don't expect you to memorize this. I just want you to know that there are these particular models available, and the neurobiological things that are the neurological things that are the brain function. That is, all these neurons working together to produce wake as an EEG on the cortex, of which you what's the newest thing here, John or Nicoletta or Eric? What is it? 1.5 centimeters into your brain? Is this what the EEG detects? It's usually between the two the electrode, and it used to be if you put two electrodes next to each other, it was the diameter around the mid distance between the two. But when you have it from, up in the in F2 to A1, I think it's sort of like the first 2 or 3 centimeters. Do you guys know that?
Yeah, you can reliably get cortical signals from as deep as about 4 centimeters, but the majority are between 2 and 2.5, and primarily those neurons that are oriented towards the skull surface. So it's a very limited selection.
Yeah, and the activity is not the things that are going toward or away from those 2 points. It's really the activity that's going in a direction other than toward it, or it's not the isoelectric. It's the other voltage. So fast, low voltages. Eye movement is vision related. Muscle tone is there. these activities of these areas are enhanced or inhibited, and VLPO in particular now has extended area as well as a clustered VLPO, and then hypocretin area is pretty high. And then non-REM sleep, slow, high voltage. These are really driven by the thalamocortical circuits, which you probably should know about and read about somewhere. You inhibit your LTD and PPT, and you activate your VLPO in the cluster and hypocretin levels. No one knows what that does directly, or whether or not these things are inhibited by other neurons. And then REM sleep is the time in which the VLPO extended is active, and it tends to activate the LTD, PPD. Now notice that this locus coeruleus has sort of like fallen off the map, and so I think that that was I don't know where that is now. So the neurotransmitters, we've kind of gone over this, but you should know that there are many neurotransmitters there. They work in wake and sleep. Serotonin is reduced during sleep. So anything that increases serotonin during wakefulness will also increase during sleep and may inhibit sleep. Acetylcholine is a system that's affected particularly by Alzheimer's. If Alzheimer's patients never got an organ system dysfunction like pneumonia or heart or kidney, they generally fade into oblivion by just being not awake. That's really the kind of the natural history. So this is a model that was put together 2006, has orexin or as a stabilizer between these two areas of the VLPO against the tumomammillary nucleus and the noradrenaline axis, dorsal raphe and histamine, and you have this sort of tip-top switch, and you have this region here which gives you your REM sleep, and you have orexin as being what they call a stabilizer. You need to know this mainly because you need to know where all the players are and how they might act, but you have to know that this particular model in 2006 is now being really poked at by a lot of very strong laboratories and trying to get at the details of each of these. I've already hinted that if you knock out the TMN, you actually can get pretty good sleep-wake cycling. And if you knock out the VLPO, you can actually get reconstitution of these things. So it's not really clear as to how these what the organizing principles are, but these are certainly developmentally determined. So on this switch, then you sort of have this thing of what gives you wake or sleep, and this balance of neurotransmitters. Now remember, somebody's sitting around reading all this stuff, trying to put it into a model and then put it into a grant and saying, well, I'm going to do this, that, or the other thing with it. But in terms of sitting there saying, can I figure this out by sitting in front of a patient? I think the easiest ones we have are if there is no orexin, then you have this, this flip-flop back and forth from wakefulness to sleep. So that comes with our sleep attacks and even our cataplexy events during wakefulness, but it comes in terms of wakefulness during sleep and the poor sleep. And when you get to see an EEG of a person with narcolepsy, you'll see in REM sleep, you can see all these features that you see in non-REM sleep. And so it's really a disorganized sleep-wake brain. Does that seem correct? You know, chime in, John, or chime in. You think of these things.
One of the key facts, I guess, that I like to tell people about narcolepsy and remember myself when we're thinking about it clinically is it's not necessarily a disorder of sleepiness, although that's what we consider it and what we treat, but it's a condition of dysregulated, unstable sleep There's intrusion of sleep into wakefulness. There's intrusion of wakefulness into sleep. And that's the fundamental pathology. So I think it, yeah, like you said, it's relevant to what we're doing clinically with these patients.
I think that's the only patient that it's the clearest that we sit there and say, okay, I know what I want to do. And what do? Well, we give them something to increase histamine, or we give them something to increase norepinephrine, or we give them something that increases dopamine. We don't hit the core problem with that. And then when we get a really sleepy OSA patient, well, you know, how to know which of these things is working is not clear. All right, so there are other neurotransmitters, dopamine, adenosine, nitrous oxide, immune modulators, probably with astrocytes, and maybe because of this glymphatic stuff. Global players for placement of state, that is, the body the hypothalamus in particular can give you growth hormone, VIP, NYP, neuropeptide Y. And then there is something in the old literature we used to call delta sleep inducing peptide, which is really bacterial cell products that produce sleep through its effects on either directly or indirectly. And what I mean is that it goes to the blood-brain barrier, which is now its research is going to be really enhanced because of its role in long COVID, but also indirectly in that there are studies, intriguing studies, that if you give LPS, which is lipopolysaccharides, cell wall products into the peritoneum and cause a sort of a peritonitis, you produce sleep as well as fever. Now you can take the fever away with acetaminophen, which works on the hypothalamus, and you still have these sleep attacks. But if you cut the vagus from the liver to the brain, you no longer have dysregulation of sleep. So the vagus goes to the NTS goes up to the hypothalamus, and they tell you when you're going to sleep and when you're not going to sleep. So, I mean, these are individual studies that people have done in basic science to be able to inform what goes on. All right. So the idea of homeostatic regulation, these are the two, this is Bourboulay in 2001, and you know, that's only 20 years ago. 22 years ago. You started to talk about this stuff, and people didn't know, how do you sleep into circadian rhythm, and how does circadian rhythm hit sleep? And they knew pretty well that homeostatic properties of sleep, that is, the longer you stay awake, the easier it is to go to sleep. Now that seems pretty, I don't know, intuitive, but is that what's happening in these guys that sit there and say they don't sleep for 24 or 48 hours and then they go to sleep for a long period of time? But it's true even for people who complain bitterly of insomnia, that if you sleep restrict them, they won't sleep long. And that's one of the features that you use in trying to institute sleep hygiene measures. And so you need to kind of be able to judge how long a person is sleeping, when their mid-sleep time is, to kind of know what they're doing. So yesterday I had a guy and I say, well, he doesn't like that he sleeps in. Well, I said, well, when did you wake up? And I called him at 2 o'clock in the afternoon. He said, about half an hour ago. So well, what time do you go to sleep? He said, about 5 a.m. So what was my next question? Well, what shift did you work when you were working there? Third shift. He loved it. He loved third shift. So you have to realize that I have to try to shift him. So the other is there's a circadian level of alertness that's run by your light dark cycle, and it shifts. And these, we always look as well as they're perfectly aligned, but certainly circadian misalignment is what we find with circadian rhythm disorders. Jet lag is being a good example of a physiologic misalignment. And it is that there are certain times of the day in which there's alertness that's increased and alertness that's decreased, and that your circadian sleepiness features here are well aligned with this 11 to 7 sleep period in this diagram by Bourbelet, who's French, so that's important idea. This is European. So the opponent process is another way that it had been produced, and that is alerting signal. And this dark line in the middle is actually a temperature profile, but it maps onto this sleep load after you wake up. And these alerting signals that increase during the day with your circadian rhythm. And that sort of lag in the middle of the afternoon is when the afternoon dip occurs. And then this 8 o'clock to about 12 o'clock, which is the also thought of as being the forbidden zone, which is even though you've been up for a long period of time, your circadian push is pushing against that sleep and keeps you up. And then as circadian falls, sleep load wins and you fall asleep, but that's at a time also when your temperature is falling. And then you wake up as your temperature starts to rise. Now, one of the questions you can always ask these people when they say that they're sleepy is, what's your best time of day and what's your worst time of day? And whether or not the last one I usually ask is, are you awake between the hours of 7 and 11 o'clock at night? And if they say no, and then they say, well, I'm asleep at 7, but I'm awake at 1 o'clock in the morning, or the opposite, I'm asleep at 1 o'clock in the afternoon, but I'm asleep by 7 o'clock at night, you sort of start to peg their chronobiological tendencies. So here's the integration. It comes together. How about that? I mean, you guys can doodle, color, use all your pencils, everything can be there. And you get this experimental light and photoperiod into your retina, goes into your hypothalamus and basal forebrain, hypothalamic signals, circadian signals. You got the other clocks, you got your sleep weight, you got a sleep homeostat, you got your ascending arousal systems in your cortex, and you have your mesopontine brainstem, which gives you your REM sleep. And then you also then go back and forth with your arousal systems. They had to do that funny box at the bottom because the REM sleep looks like wakefulness. Sorry. Okay. So we're going to go into another little section here. Any particular questions? We've been talking for about 20 minutes. It's tough stuff. It's tough stuff for me to get through too. But again, I'm trying to get through it because we're going to be seeing patients.
What resources? I mean, there's obviously the original papers, but any in particular book do you recommend?
And any chapter in any of the modern sleep textbooks. I mean, so how long do you think it takes to write a chapter?
A long time.
Well, the first thing is the person who writes the chapter knows the most about it, right? So the person who reads the chapter knows a lot more about the person who doesn't read the chapter.
That's true.
So you can go, and usually the chapter is made up of individual references, and hopefully they pick somebody, not me, who to write that thing. And it's interesting to find out who they did it. Did they do it with somebody doing human research or animal research? But you'll find all these things in there. And then you'll ask certain questions like whether or not killer whales mothers have ever sleep in the first 3 months of their pregnancy, because they have to push the babies up to breathe at the top of to the air, because the babies are all asleep in the water and they won't survive unless their mothers push them up. How about that? for all you new mothers. Imagine if you had to do that. Taking care of a crying baby is easy now, right?
Compared to that,
You
definitely.
know, being a killer whale is tough. Being a human mother is easy. That's easy. Okay. So I think, you know, if you read it up, you don't have to read it all at once, but when you get a textbook, make sure you read those chapters. Those are the ones on which you sit there. If you get a read, remember it used to be on the renal consult service, and they tell you to read a renal book,
Mhm.
and you never read the one on basic science of kidneys, right? All that stuff is there. So it's fun to read that stuff. All right. So risk for drowsy driving. I have no idea what happened here. Let's see if we get back. So something just switched. But the major thing is there. Let me kind of get out of here and put that back together. This, who knows what that happened. But anyway, if I put this, I can't even change it. I don't even know that happens. Well, you can imagine on this PowerPoint that this is the traffic accidents in North Carolina. And the risk for drowsy driving is any sedating medications and small amounts of alcohol because it adds to sleep. Driving alone long distances without breaks. Groups, male, 18 to 28, shift workers, and having an untreated sleep disorder. And this crash prevalence sort of tracks pretty well with sleep propensity and sleep things. It's pretty good. It's pretty good. All right, we'll go back to, I don't know what I did there. Okay. So we're going to go into now sleep disorders and sleep neurobiology. So this is going to, so what do you do in a visit with somebody, right? So they either get referred to you by themselves. They say, oh, I found you I found you under the Samuel Hall sleep doctor. I can make you well as a kid, right? As a pediatrician, come and see me because I'm wonderful. I use holistic and naturalistic ways, right? And you sit there and say, aha, I got him because I'm really a neurobiologist. Or they sit there and some guy says, oh, you know, you need to talk to a sleep doc because, you know, you sound like you're as sleepy as I am. Or you're doing something during sleep. So the first thing is they have to recognize it. And then you do some sort of assessment. And then you either observe them. Obviously, your primary care physician could observe them at some particular point. And I think that's preferable for a primary care. I think the first, unless somebody is hurting themselves during sleep from a parasomnia, I have no clue why these guys sit there and automatically go, refer to sleep. And then the referral says, rule out sleep apnea. And you go, okay, that's really informative. Tell me why. And I think it could be that if you could institute some simple things like stop alcohol, lose some weight, don't get a regular night's sleep and sleep longer, that all those sort of snoring things will kind of those complaints during sleep. Now, the risk factors may not change much, but the cause of sleep apnea is during sleep. And if you can improve sleep, even sleep length and reduce sleep pressure, you improve sleep apnea. So you assess them and then you test them, you treat them, and then you look for their outcome. That's what we do. Well, we now can sort of test and treat at the same time by either doing a split night, or we can test them and then treat them with a auto titration for sleep apnea. But you know, sometimes you test a narcoleptic, sometimes you have no tests at all, and sometimes the tests that you need, like actigraphy, can't be done. So you're sort of out on this limb to be able to treat these people that have real problems. Now, sometimes their problems of sleep get amplified because it's sleep, and poor sleep amplifies complaints and pain and everything else. So why can't it amplify sleep complaints? Well, it probably does, but you're sort of stuck with that as being part of your being a doctor. So why take a sleep history? Well, it's common, serious, treatable, and when treated, it improves the quality of life. And sleep disorders tell you what neurotransmitters are acting up, right? That's really why we take a sleep history. Now, from that, I'm borrowing from the psychiatrist, because a psychiatric interview, when you get down to it, and you talk to the people who really think about what the psychiatric interview is supposed to do, they are supposed to do what I'm proposing, which is that we have to map whatever is being reported by the patient to neurotransmitter systems that in their case produces dysphoria, mood disturbances, depression, manic mania, and schizophrenia and disordered thoughts. So this is an old concept. John will know this one really well. This came from the pediatric literature. If you want to teach somebody how to take a history quickly, you use the acronym BEARS. Now, I'm really not very good at this because I remember BEARS and then I won't remember what each of these things mean. But it's pretty intuitive. It's what time do they go to bed? What time do they wake up? What is their bedtime like? What is their circumstances of the bedtime? I mean, I'm sleeping in a different place and my bedtime was different, but I slept and I woke up and I sort of knew where I was, but I had to look around. But most people sleep in the same spot all the time, get used to it and get comfortable. But imagine if you're in a immigration camp in Poland, fleeing from Ukraine, or you're in a war zone, or you're in those sorts of things. So bedtimes are very different. And your circumstances of bedtime. About 20% of veterans sleep in a Barca lounger. They sleep in a tilted chair. They don't sleep in a bed. Excessive daytime sleepiness. That's what E stands for. And excessive is really you kind of have to peg it to something when you're doing your history. You have to peg it to something either that you know about or that the patient can tell you circumstances where it's dangerous. And certainly driving a car and having a fall asleep car crash is pretty excessive. Is it excessive to fall asleep in class when you have 2 jobs and you have a new child at home? Well, I don't know, but it could be excessive to certain people, and they may not be able to finish their class. Awakenings, night awakenings, early morning awakening, that's A. R is regularity and duration of sleep, and S is snoring, or more generally, sleep time noise interruptions. Whether that's inspiratory snoring or expiratory snoring. Is it catathrenia, that is nighttime groaning, which happens during expiration? What is it that people are talking about? And you'll see every now and then an example of catathrenia. That is, people who come in, they say they make these odd noises and they can't describe it, and they think they're grunting and maybe snoring or something like that. And you'll have these are people who do it all night long. And you may have experienced that if you have a cold or you have a different breathing pattern intermittent. So the dimensions I have on here, the dimensions of sleep include not only the biology, but the culture and the other sorts of things that go on with it. So where do you sleep? Owl versus lark, shift work, behavioral issues, habits, bedroom. So how cluttered is your bedroom? How cluttered is it? It's a sleep workout room, right? It's you got all your computers in there, you got your video games in there, and I'm going to go to sleep in there, or is it going to be pretty stripped down? Neurologic or psychiatric symptoms that disrupt sleep or produce neurotransmitter dysfunctions that affect sleep. Chronic illness and recovery, real good sleep distractor, and chemical substance and medication, related. Sometimes I cluster these and what are the things that attract sleep and what are the things that distract from sleep. So John, we had an interesting person, I think Nicoletta helped me take care of this lady, who came in and has been, saw Denise at one time and thought she was really sleepy during the day. And as it unfolded, she has a sister who just, she sleeps in the same room and her grandmother sleeps upstairs. And I don't know, they have, I think they have other people in the apartment. And her sister wakes her up in the middle of the night, makes her go downstairs and get water for her. And now this patient was diagnosed as schizophrenic, and maybe she is, but I think her sister is probably schizophrenic as well. I mean, it's really a chaotic scene, and it's really hard. The grandmother knows exactly what's going on, but can't unwind it. But they did an orexin level because of her sleepiness, and it was high, and she had MSLT that was like 6. But her grandmother just says she just doesn't get to sleep. And it doesn't mean get to sleep. She doesn't get to sleep, right? It's a different way of thinking. So hints for taking history of sleepiness, sleepiness versus fatigue. People will talk about sleepiness being fatigued. You can be fatigued without, or inattentive without being sleepy, but it helps. Sleep tendency in low stimulus situations or high stimulus situations. Low stimulus being, if you listening to me this morning at 8:30, having, nursed the baby all night, you may fall asleep if you were in a comfortable chair. Let's see, oh, I'm only going backwards. Okay. And then many people do not value sleep. So that's the other thing. I've got one grandchild who, when it gets to be about 7:30 or 8 o'clock, he's there, he stops, and he says, I'm going to sleep. I have the other grandchild that says, it's time to party on. And I wish I could kind of put a little mixture of both of those in there, but there are some kids and some people who really value sleep. Anais Nin, when she was writing her memoirs, talked about how she valued sleep. And she particularly liked to sleep when there was a full moon, which will be close, and open the window and have the full moon bathe her, because she thought that would give her different powers of sleep. So you have to know what their estimate. They get a daily estimate of average daily sleep. They're like, how do they like to go to sleep? Maybe that's a question we should be asking more. Do you really like to go to sleep, or is this a sort of a chore? And then the rating scales. The Epworth is it's going to go away. The future is going to be the promised SR. So decision-making, differential diagnosis. I want you guys to start doing differential diagnosis after you see patients. So usually it's a slam dunk OSA, but what if it wasn't OSA? What if it was a thyroid tumor? What if it wasn't OSA? Maybe it was central apnea. What is it? Maybe they have something else that's in there that gives them obstructive sleep apnea that is uncommon or rare. Acromegaly would be one of them, that even though you have sleep apnea, that you have or hypothyroidism, that you have particular medical entities that produce or enhance your tendency to have sleep apnea. And then does this person need further studies, and when? And often you collect more information about sleep-wake pattern and follow up, and sometimes the answer is no. It's interesting that we're doing the same number of polysomnograms at university hospitals as we did before the pandemic. We're just doing lots and lots and lots more HSTs. But the value of the polysomnogram and what you do in that has enhanced in terms of its complexity. And we're now starting to see other more complex cardiopulmonary problems come into the laboratory. So I think that there's a role for that. I think we may even try to figure out if we can create an environment in the sleep lab for more complex studies. We've got a 128 electrode array machine, John, over here in the research area that I'd love to be putting on people during sleep. I guess the techs hate it because you got to put more electrodes on. But imagine if you get regional brain activity in these narcoleptics and a bunch of controls. It's been done really. Emmanuel Mignot's AI approach to diagnose narcolepsy on just an overnight PSG. That was about 5-6 years ago. And it's just because of the complexity of signals that are seen in narcoleptic patients overnight is much higher than it is in healthy people of same age, same sex. So it's probably not that as much as maybe when we called, we already do this sort of, we want more electrodes, right? If we do seizures, well, what if we put 128 electrodes on there? I really tried to sort out what was going on. But the 128 electrode can be a poor man's MRI because it doesn't cost as much as an MRI. But yeah, you maybe do that as a nap study. I'm just sort of trying to make more value in the PSG lab. More. Can we make more value?
So to really monitor to fit that many electrodes on one screen.
Right. Or to do NIRS, right? The near infrared spectroscopy, and try to sort that out. Try to find, do it after stroke and see whether or not stroke sleep enhancing. It would be better if we had something that would change with a therapy, right? Because then we could sort of like echocardiograms. They do them. They now do them. They can do them every year, except if they have sleep apnea, they do them every 6 months. So they love to diagnose sleep apnea in heart failure patients because they can do more echocardiograms. It's really, it's cynical. Okay. So what's your plan for sleep as an explanation for a daytime sleepiness or insomnia? Yet we know that the capacity to change a sleep habit is similar to that for nutrition, exercise, or smoking. And one of the new concepts I learned at the sleep meeting is the use of our sleep psychologists to not only do insomnia, but also do other sleep disorders, including excessive daytime sleepiness. So there is a CBT-H. There's now a CBT for movement disorders in terms of trying to do non-medical therapy for restless legs, which has always been there and theoretically, and you can read about all these things like vibrators and calf compression instruments to relieve the creepy crawlies because that can do it. But as a doc, I don't know where you get those things. I can't grab it down, go down the hallway and grab one out of a storeroom, or even know how to order one. So remember sleep stages across the lifespan. I've always been intrigued by this. Sleep itself decreases across the lifespan. Slow wave sleep in particular decreases a lot as you get older, and I'm down in that, that near 75, I'm 73, so I'm down there, I'm watching my slow waves go away. It goes away faster in men than it does in women. One of the ideas is that maybe that's why Alzheimer's presents earlier in men than in women. There are now thinking that when they go it occurs more in men than women, that really they're talking about a cross-sectional study And then 10 years later, the women will have Alzheimer's as much as the men will, but you know, you're already at age 90 or something like that. Stage 2 stays about the same. Stage 1 goes down a little bit. So what does stage 2 sleep do? So when I looked at this again, as I was going through my lectures, I said, Eric will know what stage 2 does. I don't know if he's still on. John, you'll know. I have no clue. No one studied stage 2. You know that if you inhibit all the other, that is slow wave sleep and REM sleep, you'll be sleepy. But that usually shortens sleep. So independent of shortened sleep, what does stage 2 sleep do? Is that the time when the garbage trucks come out in the brain and take away all the misfolded proteins and all the stuff that goes down through the lymphatics? I don't know. Sleep latency, if you went out there and got 1,000 people in the community and measured them up and said, what's your sleep latency? And then measured it, find what it is. What's the average sleep latency? And remember, you guys are not average, so you can't use your sleep deprived. You just came off of 80-hour works, all that, or 80-hour weeks, or pregnancies, or things of that sort. That's not it. Give me a number.
15 minutes.
Anybody else? You got over under 10? You got over under bet on 10.
Rahamat
15.
says 25.
It's 25 minutes. That's the average. So when people say, "Oh, it takes me a long time to go to sleep," you say, "How long?" 20 minutes. You go, "Ah, you're not a teenager anymore, right? You're not running around all day long. You're not doing all this stuff. You're not sleep deprived." And when people tell you they go to sleep when their head hits the pillow, you know that they're tired. So this is what I tried to talk about. Now, this is the original ICD-1. They had 4 categories. And then when ICD-2 came out and ICD-3, they got much more psychiatric and said, we need disorders, we don't need conditions. Well, if people are presenting to you, you try to put them into these bins: disorders of excessive sleepiness, disorders of initiation and maintenance of sleep, parasomnias, odd behaviors during sleep, or then disorders secondary to medical or psychiatric disorders, or neurologic disorders, or something, infectious disease, whatever it is, other medical conditions. And I think there are certain things you can do things about, but I think it's useful to sort of say what the origin is. When the original groups of sleep docs got together, this is what they would organize. The first major sleep meeting that I remember was 1986 in Columbus, Ohio. And these were the areas that they had sessions about. People would get up and say, you know, and they would get up and say, I got these 10 patients I would tell you about, or I got this one patient I don't know what to do about. This is what people were talking about. The leader of the pack was Stanford, but there were other groups that came out of Stanford and knew what was going on. The basic science people in New Mexico, in Texas, in Florida, and in New York. New York and Stanford were the 2 places that did most sleep disorders. And New York did a lot of neurology. And Stanford did originally neurology and then found sleep apnea, and that's how they can establish their clinic. They started a narcolepsy clinic, the first one in the United States, but they had to close it because they didn't make any money on it. No one referred them. And the insurance companies wouldn't pay for PSG and MSLT, so they had to invent this thing called polysomnography. They had to tell an insurance company what this new test was all about. You bring somebody in at 8 o'clock at night, you let them leave at 7 o'clock in the morning, and you measure all these things. And they said, well, isn't this just an extended EEG? And they went, no, I got breathing, I got heart rate. I got video camera on them. I got all this stuff. And so they say, okay, we'll let you pay for it. How many do you do? And they would say, oh, we do 4 a month. So in 1986, major sleep centers were doing 4 PSG a month. And after every PSG, they would do an MSLT. Why? Because they could get paid for it. And they told them they were only going to do 4 a month. So what happened? Unfortunately, we discovered sleep apnea. And we didn't have tracheostomy anymore. So we had CPAP. So people are smart. When you say you snore and you're sleepy, and you got this illness, and the only therapy we have is a tracheostomy, they wouldn't even come in to be evaluated. That's happened down in Florida, or not Florida, but Australia, when Colin Sullivan was down there and kind of started to use CPAP on a regular basis for sleep apnea. He went on TV and he had maybe one person come in a month and they would offer a tracheostomy. And then now they put on TV, they said, we have this new therapy you put on their nose, and he had 10 or 12 people come in the next week. So people are smart. I really worry about these advertisements for Inspire because they really belittle CPAP. And you don't want this mask. Well, they have these people who are awake struggling with it. They don't have these people that have a good night's sleep and feel as though it's worthwhile. So I'm worried about that. All right. Okay, I think that's it. Oh, sleep restriction. Oh, so here, a couple other things. Neurobehavioral impairment is similar for short-term total sleep deprivation and chronic partial sleep deprivation, sleep debt. It's easier to talk about sleep debt. Not reversed in a single night. Perception of sleepiness less affected than measured. Performance. No, this is a good one. I put these in because I think you should see these at least once. So on the top is a reaction time. It's called the psychomotor vigilance test. And what happens is you have a little box in front of you. I think it's going to be more standard, and there's now a short one, but this is for 10 minutes. And there's a little red button that you see, so people have to be able to see it. And it turns red, and then you hit a button. Now, sometimes the light is on the left and the button's on the right, but you hit it, and it's how fast you can hit it, and you take a person on the top, and the reaction time, and those are in milliseconds. So 8 is 8 seconds. And you can see that it's between about 200 and 300 milliseconds for 70 hours if you allow people to sleep. Now, you wake them up and do the test for 10 minutes, but you let them go back to sleep. So by the end of this period of time, it gets a little longer because they have partial interruption of sleep that occurs. But as you can see, this is one of the things when I think of people who are sleepy with an apnea-hypopnea index of say 10, that means 1 every 6 minutes. I think of these tests in which they woke people up. They did this, and Tom Roth did it and said if you wake people up every 10 to 12 minutes, they generally don't feel sleepy the next day. Well, down below is reaction time in people who are a healthy person who is kept awake using EEG electrodes to see whether or not if they're going to go to sleep, they wake them up within about 30 seconds to 90 seconds when their sleep EEG looks like they're sleepy. And they wake them up, and they do it for 72 hours. And you see a couple things in here. First of all, that it takes about 18 to 20 hours before you start losing it, and it takes longer. So how long did it take at 20 hours? The average was 6 seconds. And that was 6 seconds after a light goes on to hit a button. That's pretty long. That's pretty long. And then it goes down again. So why does it go down? Anybody?
With regular circadian patterns.
Circadian rhythm, right? Yeah, your alertness is going on. So that's why when you were on call and you felt terrible at 4 o'clock in the morning, at 10 o'clock in the morning, you go, oh, that wasn't too bad. And then at 1 o'clock in the afternoon, you tank, because that would be the next day. And there you see that rise in reaction time. And then you see it go up and down with circadian rhythm. So I think the point here is that this is an unstable cognitive state, this sleepiness. And there's another study that I've always thought would be fun to have if I had a couple of these things around, is to take an untreated narcoleptic and have them do repeated PVTs and see what their, do it once an hour for 6 hours and do it for once a week for 2 or 3 weeks and see how stable they are even when they're awake. I don't think they'd be stable. So these are times in which the light comes on and the person doesn't respond. How about that? So the first studies of sleep deprivation that were dramatic and done in the 80s was they had, so you're a neurologist, what do you have? What do you have to sort of have people react? Well, they had one of those strobe lights in which they could provoke seizures. Have you ever seen that where they flicker a strobe light in front of you and try to get your EEG to do seizures? Well, they can set it to do one big strobe light in front of them. And so they would have people, so when they got to this point of 24, 48, 72 hours of sleep deprivation, they'd have people sit in a chair and they'd have their eyes open. They'd have a strobe light there. They would hit the strobe light and they say, did you see that? Right? And if you saw it, you would hit this button. So they practiced that a little bit. They'd sleep probably for 48 hours. Well, eyes would be open. Strobe light would go off. And they'd ask them, did you see that? And they'd say, no. So this is a more subtle way of showing that this is it's an unstable cognitive state. It's really, the sleep deaffinates the whole system. I mean, the light goes into your retina then puts the light to your occipital lobe and it's transferred, but it doesn't go anywhere. It doesn't go anywhere. Now, does it not go there because of slow waves, or does it not go there because of something else? So that's another experimental paradigm that would be fun to use. This is a whole group of people. This is then that was single person before. This is multiple people. 2001, sleepiness induced errors of omission, that is lapses, and errors of commissions, of false responses. What that means is that the light didn't go on, but they responded. So that's why it's so dangerous to be drowsy driving. And it comes up, starts to go up at 18 hours or so. And this is the effect of chronic persistent sleep deprivation. 8 hours, generally over 14 days, I think 8 hours time in bed. Is it really not enough time in bed? It could be, but it could be they just got tired of doing the study. And relative to baseline, but 0 hours time in bed, 3 days, you're just off the chart. But 4 hours and 6 hours gives you, it's a dose response. And this is the cumulative deficit in these PVTs. So there's a laundry list of things that cause elevated homeostatic sleep drive and what they do with predictable outcomes on sleep latency, micro sleeps, lapse of attentions. So this is 2005. I presented this at Grand Rounds. I presented, I presented this in about 2007. And the first question I got was from the chairman of medicine. It says, well, you know, all the studies you did of sleep deprivation are in, and I mentioned it, these are in college students or graduate students, and these are not in physicians. And, you know, physicians are different. They can withstand sleep deprivation. I know that after 6 months of being on call, I was no longer feeling sleepy if I was up all night. Well, the problem is the perception of sleepiness plateaus and the objective sleepiness continues. So these are the hypersomnolence spectrum that we see. This is narcolepsy. This is narcolepsy, then is serious loss of productivity. And it really is this loss of orexin. And so you know, there could be other molecules, and I'm sure there are, but I'm really this idea that when you have a hypersomnolence spectrum, that probably we should be doing orexin levels in the CSF, or people are now trying to do it in the saliva. People are trying to do it in the serum. People are trying to do it in the urine. They're doing all sorts of things that they try to figure it out. In the stool, because orexin is there in your gut, but there's no evidence that orexin is knocked out in your gut, even though there's more orexin molecules in your gut than there is in your brain. But people are trying everything. Ratio between your gut and your spit, because your spit is supposed to be blood flow. I don't know. So this is a sleep study. This is a 1998. Relax, go to sleep, pretend we're not even there. Just remember they're asleep. Frequency of sleep symptoms. This was a 2000 Punjabi. Naresh is down in Florida. He was a resident. He and I and one of the people in the AASM did the first study that included 19 different sleep centers. And they looked at their diagnostic testing that they did over 3 months for their sleep symptoms, and most of them for apneas. Also for the things we take care of. And so they about 3,000 studies, and predominant 68% was obstructive sleep apnea, but I think the important thing is that 30% were not. Now I think these other things are there. The one thing that we don't test a lot for now is erectile dysfunction, which at that particular time in 2000 was fading rapidly. But this was a comparison to sleep, a survey that was done by Coleman et al. In 1981 of all the established centers of sleep studies that had gotten together, and they found that obstructive sleep apnea was the most common, but narcolepsy was the next. OSA, are you tired, sleepy, limit your activities, do you sleep well, they complain about your snoring, how many pillows, paroxysmal nocturnal dyspnea and nocturia, sleep apnea until proven otherwise. There's some people that believe that. There's some people that are thinking about whether you could use concentration of urine in the middle of the night as an example of distinguishing sleep apnea from that. It didn't turn out. But if you're heard in the next room, the two questions: what's the decibel level of a snort or snore that's heard in the next room? And question number two: what is the odds ratio of finding obstructive sleep apnea if you're heard to snore in the next room? Question number one: what's the decibel level? You know what decibels are, huh? Wait a second. Oh, these aren't physicists. These are went to medical school. They didn't go to physics school, right? Decibels. Got a guess? Rick's got a guess.
50 to 60.
Yeah, over 60. So what is a jet plane going over at?
That's gonna be 150.
Yeah, so it's half of a jet plane. It's pretty loud. It's pretty loud. The loudest that's been recorded is a guy in Scotland. It was 96 decibels. But that's the loudest that they've ever. But you're usually heard the next one. So what's the odds ratio of finding a person with sleep apnea? And maybe that's maybe what you do is you put a microphone in the room on the other side from where the patient sleeps, right? How about that, John? That's a simple diagnostic test. Do you think I could stand up with a straight face and talk to the American Academy of Sleep Medicine on this diagnostic strategy? I'm tempted to do it just to be able to kind of get up there and give them just a, that all these people doing these diagnostic tests because sleep apnea is present and I can make a lot of money on it. I just put a microphone on an app and tape it, wireless app to tape it on the other wall. Now you'd have to have some sort of what the characteristic of the wall is sound attenuation, but if you had that little microphone and also had an ultrasound to it, you get the density of the wall, you get all sorts of stuff. So you could standardize it. See, I'm outthinking myself like everybody does with diagnostic tests. Anyway, so the next one, what's the odds ratio? It's about 7 to 8. So what's the odds ratio for smoking and lung cancer? 17. What's the odds ratio for cholesterol and heart disease? 3. So it's, it's a decent odds ratio. So remember the risk factors are what you really examine people, and you really want to know what the causes are. I'm starting a new term, John and Eric. It's called NOSA. And we have OSA and NOSA. Do I need to explain it here? So sleep is important for everyone, right? It's important for this diagnosis of sleep apnea because it's actually the adjective, right? Sleep apnea. It's not called wake apnea. So OSA has body mass, head form, and peak rate, right? An unstable airway. NOSA has ventilatory feedback, control, drive, threshold, muscle lubricating, and then there's chin. So NOSA is a non-obstructive sleep apnea, and OSA is obstructive sleep apnea. So if you have problems with ventilatory feedback, control, drive, you can have apneas, but mostly they're central. Now they're less common, but if your drive decreases with sleep to the point that it encounters a vulnerable upper airway, you'll obstruct, and it's called an obstructive apnea. If you don't obstruct, it's called a non-obstructive apnea. So I'm gonna see if I can create momentum for a term called NOSA. That's always exciting when you go to, especially international meetings, because they got OSAS. Have you ever heard that? Obstructive sleep apnea syndrome, OSAS. And it's fun. So comorbidity, development, aging, and genes. It's incredibly polygenic, and all the genes relate to all the things we first looked at. That is, sleep has genes involved in it. Body mass has genes involved in it. Head form has genes involved in it. Ventilatory feedback control has genes involved in it. So it's a polygenic complex disorder where no one gene or no one trait determines that particular syndrome. And and your interface with the environment to get oxygen. Insomnia, poor sleep when you sleep, when you wake up, when you feel. Mainly you're mapping this to circadian rhythm. You're mapping this to sort of your neurotransmitters. You're mapping this also to their sleep environment and to your drugs that they have. Common, serious. Lost productivity from insomnia is thought to be greater than that from OSA. Sleepiness, hypervigilance, sleeplessness. That's the term that the Johns Hopkins guy, Sushil knows it very well. He calls it sleeplessness instead of insomnia. It's a good term to kind of get in your head. This person, they say, I complain, because what it does is it gets you out of the symptom and into a process, which is sleeplessness. And anxiety is CRF and maybe orexin, high orexin levels. Then circadian, the big one, circadian misalignment. Advanced or delayed feed. So I think sleeplessness is a convenient term to start thinking about when you hear insomnia, because then you think of all the neurotransmitters, you think of the circadian rhythm, you think of distractors, you think of anxiety. And I think anxiety is something we really have not, that's one area where I hope Kamal and the psychiatrists can help us break it down. Kamal's already started to help us break down the anxiety issue and what to do and how to do it. And anxiety is best treated in people who are not psychologically or psychiatrically diagnosed by cognitive behavioral therapy. So that's regulation. Remember that your cognitive affective system. Parasomnia, often worse with sleep deprivation. Oops. Benign hypnic starts, cataphrenia, sleep talking. Those are relative. Hypnic starts you'll hear a lot. They're more problematic. Sexsomnia was described and made a diagnostic entity about 6-7 years ago. Came out of the same group that described REM behavior disorder. And whether post-traumatic stress disorder is really a parasomnia or is it something that we exclusively treat, that's why I put it sort of down there and how we treat it. 4-second lapse in attention to have a drowsy driving crash. And you've seen that if you're sleep deprived, you will not react for up to 6 seconds sometimes. It's usually drive off the road right, drive off the road left. There's no skid marks. The person doesn't try to get themselves away from the bridge abutment. Risk factors. Taking any sedating medications, it's multiplicative. Having a sleep disorder, driving long distance. Driving home post-call, good one, good one. Those are the times in which car accidents reported in interns. Over a year study of 18,000 interns. These are when they had near misses or traffic accidents. There were no deaths, fortunately. So these are things that we think have evidence-based for recognizing signs. Trouble focusing on the road. Why is that? So you tend to go to sleep from your occipital lobe to your frontal lobe. And you've all experienced it when you're reading and you get really tired. The first thing is it looks like the print is pretty blurry. And so that's part of what's going on. Difficulty keeping your eyes open. There are people that sleep with their eyes open. So there are animals that sleep with their eyes open. So in humans, at least, having difficulty keeping it open. Nodding. Nodding is the loss of muscle tone that occurs with sleep onset. Yawning. Who knows? I mean, you look up yawning and you look up animal behavior and you find threat behavior. They want to show the incisors, but that's not what's happening when you're going to go to sleep. Drifting from your lane, missing signs or exit, not remembering driving the last few miles. That's automatic behavior. Automatic behavior is probably engages the same thing as in which there's retrograde amnesia. If I woke you up in the middle of the night and you go to sleep within 2 minutes, you won't remember I woke you up. If I woke you up and said, I want you to remember a blue car, and I have you go to sleep in 2 minutes, you won't remember I woke you up or what the question was. If I let you sleep, if I keep you awake for 4 minutes, you may or may not remember you woke up, and you may or may not remember whether or not it was a blue car that I told you. These are experiments people did. Now, closing your eyes at stoplights, that's a classic one that all the interns and residents, when we did a drowsy driving survey across 5 different medical centers and 7 different specialties. This is the equivalence of which you find after about 17 hours of being awake, you're equivalent to 0.05 level of alcohol. And if it's 23 hours, it's about 0.1, and then it goes up. And why does it go up? Circadian rhythm, right? But that's one of the driving points for 18-hour days, not letting interns be on for 24 hours. And that was a compromise because everybody said, oh, you can learn how to do that. Well, it is true on an individual basis that you kind of learn to adjust to sleep deprivation. You know when you're sleepy, and you rely a lot on nurses, other parts of the team to not make errors. And while there was an observational study of an MICU where they compared 18-hour shifts to 24-hour shifts, it was 36-hour shifts, 18 hours to 36-hour shifts, that they reported more errors that were observed, but they didn't really get to the point where people would make mistakes because there was too much redundancy in the resident and the fellow and things of that sort. It doesn't mean it couldn't happen. But when we did our studies of the qualitative experiences, we had some interesting quotes. It was after you've been on for 24 hours, someone sort of complains, and you get called of a complaint of a person having crushing chest pain, and you go, oh, crushing chest pain? I got to wake up for this? You go, oh my goodness. So it's just not really caring professionalism. And those comparative impairments have been shown to cognitive slowing, decision skills errors, and high coordination and divided tasks. And the eye-hand coordination has been played out with the procedures that are done laparoscopically and with the training. Sleepiness, alcohol exhibit dose response. Sleepiness, alcohol impair a person's perception of impairment and interaction effects between the two. So that was it. Physiologic regulation of sleep-wake states, neuroanatomy and neurobiology, neurochemical control, integration of sleep-wake states and circadian rhythms and clinical presentations, integration of disease and implications for treatment, integration with society. And notice the gaps, right? Only narcolepsy has orexin loss, and insomnia is with anxiety, CRF. And there are attempts at getting CRF blockers for anxiety as well as in psychiatry. We played around with it in animal models of anxiety. Doing history and physical, rarely find discrete neural pathways. And you compare that to neurologic diagnoses and heart disease. And the people who really think about sleep sort of think that we're fluff medicine because we don't do that. I think there's basic science to it, so that's why I keep pushing on this. Doesn't mean we don't help people, but they say, well, you know, you're not digging people out of a grave, right? You're not treating stuff that can kill you. So that's the downside risk. So Rick, you were asking me about why sleep medicine. Well, that's it. It doesn't have the excitement of MICU. It doesn't have excitement of seeing somebody come in with burnt out, you know, IPF, right? Doesn't have the excitement of people coming in coughing because they've smoked cigarettes for 50 years. And it's not, I like pulmonary medicine. I think it's really interesting, but I like the basic science and the developmental aspects lung disease, and the prevention aspects are so important. So important. So if you were in preventative medicine, or you were in smoking cessation, or you were in something that would prevent the origins of that disease, that's really kind of, I think that's, but you can see my bent is really this, and probably why I went into sleep medicine. I like the psychological and mental effects of these things. My choice of going into specialties was pediatrics, psychiatry, or internal medicine. I chose internal medicine for two reasons. They were really, I ran away from pediatrics because I didn't like to talk to parents. And I ran away from psychiatry because you didn't do a physical examination. So I kicked the can down the road and then found pulmonary medicine research, and then pulmonary research ended up with sleep. And then sleep started this thing going. So what'd you think? Nicoletta, I don't think you heard this last year.
No, not this one, Dr. Strohl. There was another first lecture that I was able to attend, but not this one.
I
What
did
did-
give
what
a
did-
lecture on neurobiology.
Yeah. So what do you think, Eric?
No, I thought it was really good. I like the history part that you added in here. So, but I think my talk then was, I tried to make it less dry because of the, when you see VOPO and then you automatically dry it up. So, but I think, yeah, I added a couple other YouTube videos to try to make it interesting. But then I think the history part really, just ties the whole thing in together, and of course, who is better to talk about history besides Dr. Strohl?
Well, I think the reason to think about history is that this all started somewhere, and this is all going to go somewhere. So what you guys are going to see in the next 20, 30 years are going to be, what are people thinking about? The origins of this are going to be very smart people seeing patients and very smart people doing animals. And somewhere in the middle, that has to be translated into what goes on. And the history sort of tells you that people sort of went one step at a time. And the idea that they did MSLTs after every PSG is really intriguing, because that's the only place that everybody, it ends up by you say, well, you shouldn't do an MSLT after you've done a sleep study that shows sleep apnea, right? And you say, is that true? Is that really true? And you ask that of people, and people go, well, that's what the book says, right? And you'll go, well, where'd the book get this reference to? And they sort of go, everybody knows, right? And you go, no, that's not it. And you go back to the 1980s, and they sit there and they say, well, when we knew they had sleep apnea, we were doing MSLT, and maybe they would have one REM onset during an MSLT, but they would never have more than 2 or 3. They would have, rarely have more than one. Rarely. I mean, and they were saying we were doing this a lot and across studies, and they were talking about it. I don't know if there's probably one paper on it saying that you can see REM onset in a PSG after an OSA. So people then automatically assume that it wasn't relevant, and people would say, well, it's just a question of degree.
There were a couple of interesting discussions on, along the same line, narcolepsy and idiopathic hypersomnia. And there was a debate that was pretty interesting. Was idiopathic hypersomnia a distinct sleep disorder? And obviously one side is, yes, it is, a separate entity on its own. And the other one says it's not, just for the sake of argument. And I think the one that says that it's not a distinct disorder, the argument basically is based on that we do not know of a pathophysiology, which I didn't think was very convincing. But anyway, so there's a lot of things that we still don't know yet, and that's why we're here. Get more people trained and interested in things like this, and the pathophysiology thing, the basic science is still very crucial in helping us to understand. just kind of want to add that now.
So what should we call this new diagnostic test, putting a microphone on the other, on one room away from the patient?
How far is the room?
I
And
don't
how's
know.
the
I mean,
soundproof?
there are a lot of things. I mean, how tight is the ring, or how broad is the band over your head, and all those. The one I'm advising on is this thing called Breezatech, which you put underneath your chin, and it measures your flow and snoring and ballistics and everything that everybody measures and everything else, but they do it around the neck. Sort of like the CNAP, except it has except it measures everything there. Has an oxygen saturation that's built into it too. So everybody can do it. I mean, the technology is there to do whatever you want. So you just have to repackage it, and then the next step is selling it. And it feels too crowded to make a lot of money on it.
Sorry,
Fair
guys,
enough.
I gotta go. I gotta hop onto another meeting, but I
Yeah.
will see
Okay,
Nicoletta
so-
and Ramad this Thursday, and hopefully at some point I will see Samuel and Rick.
All right.
Are we coming back next Tuesday for the thing
Yeah,
here in person? I think
yeah.
that might be a good idea.
yeah,
All right,
okay.
we'll make sure we get that happen.
And Suzanne, you can zoom in. We'll be on Zoom too.
Yeah, we'll still broadcast through Zoom, but I think it might be good for us to kind of start at least together for a period of time.
Yeah.
Hey, I have a
Who's-
quick question
Mhm.
about Thursday clinic. So Dr. Ye, I just show up to Bowell 6th floor on Thursday.
Yep.
Yep.
We'll
Okay,
explore Thursday.
And
Be
tomorrow
there-
too.
be-
That goes
be-
for
be-
tomorrow.
tomorrow too.
Oh,
Be
no,
there or be square.
It will be today for you. It's Tuesday.
That's what I meant. I'm sorry, Tuesday. Yes, today is Tuesday.
Yeah,
Yep.
and then tomorrow you guys all belong to Sally. So
Pediatric, yeah.
And that's in Landerbrook.
Yeah.
Yeah. So what do you guys think of that lecture? Was that informative to you? Was it too much? Was it too little? I mean, you're not going to remember all the alphabet soup.
No, it was definitely a good introduction. Like
Yeah.
I made notes to go back and, go back, review my neuroanatomy again.
Yeah, well, I'll put this into a PDF and send it around.
Oh, that'd be great.
Okay, go get them.
Thank you, Dr. Strohl.
Stamp out sleep disease in our lifetime.